Thank you very much, Maria, and thank you all for being connected live with us. It is an honor to share this speech with Dr. Santos, and I also want to thank Candela for its confidence in me. So we're going to start about describing the power or the armamentarium that the Nautilus has to treat vascular disorders. The idea of this device is that it has two systems that permit to treat different depths, and that's very interesting when we're talking about vascular lesions, right? So we have the neodymium that allows us to reach deep vessels, and we also have the intense pulsed light or the selective waveband technology, which is called in the Nautilus, that allows us to reach superficial and mid-depth vessels. So with just one single device, we can treat all type of vascular lesions. So the first question when I am in front of the device is what handpiece shall I choose depending on what I want to treat, right? So these are the different handpieces that the Nautilus has for its IPL, right? The most used ones are the PR 530 and the VL 555. The PR530, it does not mean that it only emits at 530. It's an IPL, so it has some filters in it, and it emits between 530 and 750. So this handpiece is more superficial, it's more aggressive for the superficial melanin, and as so, it's more efficient if we want to treat superficial pigment. On the other side, we do have the VL handpiece that emits between 555 and 950 nanometers. So it's thought to be used for deeper structures. So it's safer for the superficial melanin. So it's less efficient if you want to treat pigment. Okay, so this is an overview of the handpieces that the Nautilus has in terms of the IPL. Here we see the wavelength spectrum and all the absorption that hemoglobin has. And we see that with the PR and the VL handpieces, we can aim, we can aim to different depths of that structures, and we also have the neodymium that goes very deep. All right, so we can reach a lot of depths in our skin. So the theoretical recommendation on the IPL of the Nautilus is using the VL handpiece for violet structures and also for lentigos because it's safe. And the PR handpiece should be used for pink and red lesions. But it's a recommendation, but it's not obligatory or compulsory to follow this rule. Actually, if you want to treat melanin, we can use the VL for darker pigmented lesions because it's a safer wavelength because it goes deeper. But we can use the PR for light and intermediate pigmented lesions because it's more superficial, so it's going to be more efficient to treat superficial pigment. If we want to treat the hemoglobin, we should use the 555 handpiece if we want to reach deeper vessels, so they are darker and bluer. But if you want to reach, more superficial vessels, which will be red or pink, we should switch to the PR handpiece. All right, so we see that with both handpieces, we can treat either melanin or hemoglobin, and we can also switch between depths in our skin. All right, so this should be my advice or the way I use these two handpieces. So when I'm treating darker phototypes or when I'm treating a pigmented lesion that has abundant chromophore, or if I want to treat simultaneously lentigos and deep vessels, I use the VL handpiece. And on the other side, if I want to treat lighter phototypes, or if the pigmented lesion has scarce chromophore, or if I want to treat lentigos and superficial vessels simultaneously, then I switch to the PR handpiece. All right, so that would be my general advice on how to use these two handpieces. So what is the Didac intended for? This third handpiece is used for deeper and larger vascular structures. So normally, whenever we see vessels that are wider than 1 millimeter approximately in diameter, we may switch to the neodymium YAG. It's also very powerful. You know, most of the IPLs work between approximately 10 joules by square centimeter, and the neodymium is a laser that works approximately at 100 joules centimeter square, right? So it is a very potent laser. So it's intended for high flow vessels when I need a lot of power to collapse that vessel. For example, the nasal LA telangiectasias. It is actually this indication is dangerous if you use a high potency laser as the neodymium, but it's the most effective one, okay? And the neodymium is also intended to be used more in the body than on the face because it's the more aggressive or dangerous laser, right? It may have, I mean, you may see a very good end point, but you may have an unpredictable result with this, right? It's not strange that you can cause some ulcers or crusts in the nasal LA if you use the neodymium YAG at high energy, right? So most of the times, if we're treating vascular lesions in our body, we should use the neodymium YAG. And if we use the YAG for the face, we should be careful with its fluids. So the second question when I have selected the handpiece of the Nautilus is answering if I need a single or a double pulse, right? And the rationale behind it is because if I do a double pulse, I transform the oxyhemoglobin with the first pulse into methemoglobin, right? And it changes the curve of absorption of the hemoglobin. Methemoglobin has more absorption for the second shot, right? So if I see a structure that has scarce chromophore, for example, I tend to use a double pulse. So I make sure that with the second pulse, the structure will absorb the second shot, okay? It allows me to use less energy if I use a double pulse because methemoglobin has more absorption, and then I'm making a safer treatment, all right, because I'm using less power. So as I said, if the scars is chromophore, it is a good idea to take profit of the second pulse. If you leave some space in between the first and the second pulse, the skin cools down, so we're increasing safety and we are reducing the risk that the vessel explodes and causes purpura, right? So the double pulse should be for increased safety and for vessels that have little chromophore. Now I'm just going to show you some clinical cases. Dr. Santos will show you many more, right? I've spoken more theoretically than he will. And let's see here some clinical cases. So we see an erythematotelangiectasic rosacea here. We see some areas that do have diffuse erythema with little chromophore, but we also see large vessels with a lot of chromophore, especially on the nose, right? So I selected the PR handpiece because this patient is light-skinned and these vessels are superficial. So that's why I chose the PR handpiece. For the diffuse erythema, I first made a pass of a short pulse and a high fluence because I'm treating small structures with scarce chromophore, and that's what they need. And for bigger structures with a lot of chromophore, what I will use is a long pulse and low fluency, right? So what I did is a first pass of 2.5 milliseconds, 6 joules for the diffuse erythema, and then I switched to 9 milliseconds and 10.5 joules for the large vessels, right? So this is the before, and this is the after one single session with these settings I told you. I would like to do the second session for the nose vessels, but the patient was happy enough with the result of a single session, so he decided not to go further with this treatment. All right, so here's a very common case. These are perinasal telangiectasias. This patient was first treated with the Nordlis with a double pulse of 1.5 milliseconds and 6 joules, and it did not respond. Okay, so when I saw this patient, I thought these were mid-large vessels and that they had a scarce chromophore, so I thought it to be better to use a PR because they are superficial vessels and it's more aggressive. And I used just one single pulse, mid-length, because it's a quite big structure, and mid-high fluence, right? So these were the settings that I used for this case, and this is the before and after. So the first time that this patient was treated with 1.5 milliseconds, this pulse is too much short for this such big structure, right? So here's the trick. This is the last case I'm going to show you. This is one patient that has a capillary malformation and spider nevus, right? Because these two structures have superficial and deep component, I used the two hand pieces of the Nordlis, right? I first made a pass of PR to treat the superficial vessels with the settings that you are seeing here. And secondly, I made a second pass in the same session to treat the deep structures, right? So for the spider, for example, I used the PR for the peripheral vessels, and for the central vessel, I used the VL handpiece. So my overview on the Nordlis in the treatment of vascular laser, of the vascular, lesions, is that is a useful device for any vascular lesion because it has different wavelengths, so it permits you to get to superficial and deep vessels. It normally does not cost purpura if you compare it to the classic PDL settings. It does not have consumables. It's more eco-friendly than the PDL, and it's also great for pigmentary disorders. You can actually treat lentigo simultaneously, and you cannot do it with the PDL, right? So these should be the advantages of the Nordlis in front of the PDL. It also has another hand piece to stimulate collagen, which is the non-ablative fractional laser. So with just one single device, you can treat pigment, you can treat hemoglobin, and you can also treat collagen. So that would be my overview of the Nordlis in the management of vascular lesions, right? If you have any question at the end of this session, we'll have a Q&A section. And now I'm just stepping aside, and Dr. Pedro Santos will follow the speech. So thank you very much.
Hello, everyone. First of all, thank you, Didac, for your magistral presentation. You made my life pretty easy right now. And I would like to thank you all to be with us this evening, to discuss a little bit more of vascular treatments using Norderlis and his patented technologies such as the selective waveband technology of its IPL that is unique on the market. So let's cover a little bit of everything on vascular indications. But first of all, I will only like to summarize a little bit what Didac told us. So when we face a vascular problem that we want to treat, and after having obviously the diagnosis of the lesion, we first have to select the handpiece. And the PR should usually better on pink and red lesions, and it's easy to remember because PR we have just the two letters for guide us, and guiding us also on the VL we have the violaceous lesions, but also on lesions that have higher chromophore density, for instance. We also have an NBI available that will suit us to treat dark or deeper lesions and is safer to use on dark or tannet phototypes. Concerning the pulse duration, we will divide, and I will divide this presentation into major groups: the microvascular issues and the macrovascular ones. In the microvascular issues, we should follow a strategy of short pulse, either single or double, as the doc already told us. And our short pulse will always be below 8 milliseconds. If we have a macrovascular structure to treat, we will use mainly a single pulse with 8 milliseconds or more. Probably you are asking how to divide a microvascular to a macrovascular, and basically we divide them with our eyes. Is saying that if we can clearly see the structure, we are on behalf of a macrovascular one. If we can't individualize the vessels on the structure, in this case we are facing a microvascular lesion. About the fluence, I would like to remember a tip and a trick to use safely the SWT technology, that is to decrease 1 joule per centimeter square on bony areas and reduce furthermore 25% on thin skin or on extrafacial areas. I would also like to remember you that we should increase the fluence with low chromophore density to achieve the needed results. Starting with microvascular indications. First of all, and I think the most common one for everyone on the audience, is rosacea. So following a flow chart to set up your treatment, first of all, you should assess the chromophore density. And obviously, we know that our rosacea usually has a chromophore that runs from pink to red. So our main handpiece to go is the PR 530. If we are facing a diffuse redness, just a diffuse erythema, we should go with a very short pulse, around 1.5 milliseconds. And if we are facing a microreticular telangiectatic pattern, we should go with a double pulse of 2.5 milliseconds with a delay between them of 10 milliseconds. And this will increase the efficacy, as Didac already explained us. We should always overlap with this technique, around 50%. Why? Because when we deliver the energy on the skin, the energy will suffer diffraction, and below the skin surface we will have like a cone facing with the bottom to the skin of useful energy. If we overlap, we get a uniform penetration along all of the lesion to treat. After this, we should be care about the pressure that we perform the treatment, because if we exert too much pressure on the skin, we will take out the chromophore that we need to treat this condition. Usually, we need 2 to 4 sessions, 4 weeks apart. And as rosacea is a chronic skin condition, usually it's needed maintenance, but usually as the course is different from every other patient, what we should tell the patient is that we don't schedule the maintenance, but when the patient start to feel symptoms or see redness, you will need to come back to perform 1 to 2 sessions, and usually this happens 1 to 2 times per year. Here we have some results. On the first side, we have just diffuse erythema, and with 3 sessions of the very short pulse of 1.5 milliseconds, ranging fluences between 5.5 to 6 joules per centimeter square, we have this nice clearance. I think that probably on the audience we'll have some PDL and KTP experienced colleagues, and you know that sometimes the diffuse erythema and the flushing is quite hard to treat and quite hard to have a significant result. So if we use the IPL that allow us broader coverage, we sometimes get better results when compared with these other two technologies. On the other hand, at the right side, this is a patient that has a mixed condition between photoaging and some rosacea. And with a single treatment with the double pulse strategy for treating the photoaging and the vascular part, you can see a pretty nice clearance on the vascular part. Talking about another microvascular condition, talking about capillary malformation or the benign vascular tumors, such as the hemangiomas and port stains, the flow chart that we should follow, the structure is pretty much similar to the rosacea. But first of all, we will assess the chromophore density, and if we have a pink or red lesion, we will go with the PR. If we have a violations one, we will go with the VL. On this case, we should always double pass. And this is being stated by several papers. And the first pass is to induce the generation of methemoglobin, and for reducing the thermal impedance of the skin and of the lesion. And we should do the first pass with a not so short pulse of a minimum of 5.5 milliseconds with medium fluence, ranging between 7 to 9 joules, and a second pass that the idea is to be photopurpuric in inducing a pretty amount of purpura with a pulse duration ranging between 0.5 to 3 milliseconds. At this point, even if we wish to go to a non-purpuric setting, we know that for treating capillary malformations and vascular tumors, the efficacy is still pretty much significant with the purpuric strategy rather than the other one. On this case, as we are inducing bulk up eating of the lesion, we should wait 6 weeks to perform next sessions of the treatment of these cases. Here I'll share with you a case of a port wine stain of a 3-year-old girl, and with just 3 sessions, we actually have a result that is pretty similar to a PDL device. So we can actually achieve a nice amount of purpura even using an IPL. And this is because we have the only IPL on the market that allow us to perform a single pulse with a duration below 3 milliseconds. And we can also eventually reach the 0.5 millisecond pulse with Norlis. And this is pretty a unique setting and feature of this system. Passing to the macrovascular indications. Here we will discuss the telangiectasias and other vascular lesions. Basically, the flow chart is pretty much the same. We will assess the predominant chromophore tissues, the NPs, pink and red, the PR, purple, the VL, and if we are facing a darker or deeper lesion, the NDAC. Here we will use the selective photothermolysis theory, as we are increasing the pulse duration with larger vascular volumes or with increased dimension of the lesion, and the reverse is also the same. When we treat single and isolated lesions, we should always isolate the surrounding skin to not damage structures that we don't want to. Basically, this is a short version of the SPTL theory applied to vascular lesions. And what we are using on concrete vascular and macrovascular lesions is what we call mainly a square pulse. What is a square pulse? Is roughly a structure of pulse that have the same fluence for the same pulse duration. And with thin vessels, we will use 8 to 10 square pulse. With a medium vessel, 11 to 13, 14, and with thicker vessels, 15 or more square pulse structure. Here we have an example treating macrovascular structures, on this case, telangiectasias on the face with pretty high volume. On this case, we are using not the PR, but the PRS from small. If you check on the video, it's an hexagonal small handpiece for precision treatments. And we are using a 15 millisecond pulse duration to photocoagulate these lesions. Here is an example using the VL as we are facing darker and deeper lesions. Here the VL is the way to go with a square pulse of 15 joules per centimeter square. Here another example, more thin telangiectasias and more superficial. So the way to go is to use the PR with the square pulse too. We can also treat cherry angiomas, and this is a pretty nice indication that goes well almost with any applicator, even the PR, the VL, and the NDAC too. And usually with a single session, we have a nice clearance of the lesions. Here, Venus Lake, a pretty dark lesion that can be treated with the VL, but for me, as this is a high volume vascular lesion, for me the way to go is the neodymium YAG. And here you see a single treatment where we have a complete clearance of the lesion and without any scar left behind. We can also treat leg veins, but on the leg veins, with Nordwis, we should only go with the NDAC because the IPL is not enough to get to the depth of this vessel. So legs is a synonym of using NDAC. Let's cover some other indirect vascular indications, such as active acne. For me, this is a mandatory indication. If you manage acne on your practice, it's a pretty nice help to other treatments, even with oral retinol derivatives such as isotretinoin. and we know that we don't have an important risk using and combining these two strategies. And IPL is useful because we know that we have a thermal sebaceous downregulation. We have a bacteriostatic effect on the C. acnes because of the activation of the protoporphyrins and reactive oxygen species generation. And we also have significant evidence for this low wavelength of its anti-inflammatory effect. So if we are facing an active acne, we should use the PR530 with a double pulse strategy, ranging effluents between 6.6 to 8 joules per centimeter square. And please don't forget the acne-related erythema, the erythema that is left after the main inflammatory part of the lesions is gone. But please remember that this erythema is a surrogate of inflammatory activity too. And here we should go with a very short pulse of 1.5 milliseconds. Our endpoint is a superpuric one where we can appreciate the darkening of the lesion and immediate fade out of that darkening. And usually this is achievable with effluents ranging between 5 to 6 joules. Here we have an example of a patient after 2 sessions of the PR to 530 and combined with oral isotretinoin 10 milligrams per day. And we all have to agree that this is a very nice control of the pathology. And please note that even the residual erythema is pretty well controlled. For me, the very nice indication is the periocular photorejuvenation on the vascular part of the under eye circle. If you notice here, we have a reduction of the vascular component, and even the shadow that we have here is pre-reduced with only two sessions of PR. What we do is to perform vertical applications of the PR530 with a double pulse strategy. And usually with 3 to 5 sessions, we have a pretty nice clearance on the vascular part of the dark circles. Another indication that is rising every day more is the inflammatory part on the blepharitis. And this is one of the indications that is supporting every day more the anti-inflammatory effect of the IPL and SWT on inflammation, modulating some ILs, namely the 17 and the 34, on the inflammation on these cases. Let's go a little bit beyond vascular and talking about numbers. 9 out of 10. What could this represent? If we go through some pretty common indications and concerns of our patients, if I asked you how many patients do you have without any of this one, such as photoaging and all of its consequences, rosacea, other micro or macrovascular issues, textural impairment of the skin, wrinkle, active acne or acne scars, surgical scars, traumatic scars, strias, even red or white, leg veins, warts, onychomycosis, HPV, skin infections, or unwanted hair. Probably you won't find any of this or any patient without any of these conditions. So if I tell you that 90% of your patients could use a Northwest treatment, this is actually true. So please have all of these indications in mind and acknowledge that adding technology to your practice is a differential way to present you to your patients and to outstanding results and bring the results to another level beyond the traditional techniques and non-technological ones. For finishing, we all have to agree that Norlis has some unique features, and on SWT, I would like to outstand and outpoint the narrow band that allow us to have more efficacy and more safety on our treatments. We can be more effective with fewer sessions, with less fluids than comparative technologies. We have a scalable technology that allow us to grow with our machine and adding more applicators. We have, rather than the SWT ones, we have two non-fractional ablative lasers, the erbium glass one of 1550 and the thulium one of 1940. This last one is the last addition to the system that allows us to treat more superficially and to deal pretty efficiently with diffuse pigmentation and eventually with actinic keratosis. And when we talk and when we face vascular indications, if we combine on our system a PR, a VL, and an ND piece, we actually have a complete vascular station treating almost every condition that is treatable by technology. We have a user-friendly platform with a user-guided interface. We don't have any consumable, so it's a profitable with a low running costs, and we can, with all of these, provide high satisfaction rates for you and for your patients.